I'd like to talk about study designs, and I think this will be important to you if you're a student. Um, Probably you may wish by the end that you'd had this part of the course a long time ago, but maybe it will just reinforce ideas and knowledge that you already have. And a real good review of this last material is to look at the course outline because I'm going to follow that course outline very carefully. And I want to cover two particular topics with you in these last two lectures that I'm going to give, or the last several lectures I'm going to give. I'm going to focus on epidemiological study designs and the statistics that correspond to them. So every study design has specific statistics that go with it. And then I'm going to talk about causality because people think that they know about causality, and I'll tell you what the school answer is about causality, and I think you'll feel very comfortable with it. So let me just look down here, and what I'm going to do is, whoops, let me back up here. Um, Maybe I should start over. Let's just start over.
Yeah, just start over. I'll edit since it's at the beginning.
Let's start here.
Yeah.
Okay, what I want to do is I want to talk about study designs, and probably a good way to follow this section is to review the course outline because I'm going to follow each of the topics as outlined on the course outline. But there's two topics that I want to cover in these last few lectures, and that's epidemiological or epidemiologic study designs and the statistics that correspond with them. So for every study design, you have a specific statistic or numbers of statistics that go along with that study design. And then I want to talk about causality. A causes B is really what we're talking about. And a lot of people think that they understand how to evaluate or judge causality, and they often use causality inappropriately. And I'll help you not to do that, so that you're informed. Okay. Um, let's see. Um, the next uh, the next slide um, will help to differentiate the two types of study designs that we're going to focus on. I want you to notice that we're going to focus on experimental studies, and next we're going to focus on observational studies. And at the top it says that these are epidemiologic study designs, and I want to differentiate, or you might say that these are medical or epidemiological studies designs, but they're not study designs from the social sciences. The study designs for the social sciences originally came from a book, and if you can get it, it would be probably a good idea to have it in your library. Is by Campbell and Stanley, published in 1963. Actually, it was a book chapter, and they published it separately, and it was a standard for psychology and many other disciplines, and even medicine and epidemiology refer to these social science study designs when they seem to be the most appropriate in addressing a particular question. But at any rate, we're not going to focus on the social science study designs. We're going to focus on the medical and epidemiologic study designs. Now, when we look at an experiment here, I'm going to ask you a question. What makes an experiment what it is? What do we usually say an experiment involves? And the first statement people usually blurt out is, oh, it's randomization of participants. That's not the case in an epidemiological or a medical study design. It is assignment of conditions manipulated by the investigator. So your answer is assignment of conditions manipulated by the investigator. That's what differentiates, or that's the definition of an experimental study. Okay? So you want to keep that firmly in mind and not lose sight of that. It's not randomization. So if somebody says, now in the social sciences, the big thing is randomization. In an epidemiologic study, it's the assignment of conditions manipulated by the investigator as to who gets what. Okay? Now, I also would like you to know that the study designs I'm going to talk to you about are known by many different names. Everybody seems to want to be associated with or have their name or their paper or their study associated with a study design, and then it should be called by that name. So I would say it like this: whether you call me Ted, Ned, Fred, or whatever, I'm still the same thing. And I'm going to teach you traditional terms that you can translate if you see them in any other form or any other format. So be leery of that, because many of them have been relabeled so people can take credit for them. And I'm certain you've seen this in other areas too, and it's happened in this area as well. So no matter what you call it, you can translate the information and the labels that I'm providing to you for to other names of the same thing. Now, I'm going to try and peel this like an onion for you, so we go in a systematic fashion that you feel comfortable and you know what's coming up and you know how to differentiate things. So with an observational study, what we mean by an observational study is these are the things that we observe in nature. Okay? We observe the occurrence of a disease. We don't have control over who gets the disease and who doesn't get the disease. We observe those that are diseased, or we observe an environmental influence. If you take a tornado, we're observing what has occurred after the fact. And when we talk about observational studies versus experimental studies, we note that under experimental studies there are community trials and there are clinical trials. And under an observational studies there are four types: case control, historical prospective, and cross-sectional. All right? So if we look at an experimental study versus an observational study, you notice that we have a defined population in both cases. Usually with an experimental study, we draw a sample at random, but it could be non-random. But the primary distinction, again, that the assignment of the conditions is manipulated by the investigator. In the observational study, we have a non-random selection of subjects into study groups, and this is we're observing what happens in nature. Then in both cases we have a random sample, a study sample, and then lower down in this diagram you see the random allocation and I will show you an example of that, of the random allocation, and I will show you experimental studies, and we will talk about those. And in this case, it's assessment that determine whether people are in Group A or Group B. Okay, so I hope that's clear thus far. Now, experimental studies. Now notice this. Studies where the experimental conditions are under direct control of the investigator as to who gets what condition. Effects are measured by the following: comparing the experimental and comparison or control group. To avoid bias, members of the experimental and control groups should be similar in as many ways possible. Okay, so we could fill up two groups, and then the investigator could decide this group gets condition 1 and this group gets condition 2. Now, if we were assigning at random, we would put a person in group 1 and a person in group 2, and then maybe it would be 2, 1. They would just go into groups at random. Now, we're talking about filling groups and then labeling who gets what condition. So that's an entirely different strategy than what would probably go on in the social sciences. May only be able to randomly assign conditions, is what I'm saying, and not participants to conditions. So random assignment is not one of the distinguishing features of an experimental study. It is the investigator's control as to who is assigned to which condition. And I also want to add that what is the difference between a comparison group and a control group? A control group actually receives no treatment, and a comparison group receives another type of treatment. So with a comparison group, you may, if you're doing a drug study, for example, you're going to compare drug A to drug B. So in a control situation, you would compare drug A to possibly a group that received no medication. There are different types of control groups. I want to mention that there are attention control groups for the attention that people receive, where you just have participants come into a clinic, for example, but provide no real treatment other than attention. And this is sometimes known as the edifice control, where the status of the institution has a positive placebo effect. For example, an intervention from Stanford, where the university is revered and people want to participate just because of the reputation of the institution. A change may occur just because people do not want to let the institution down. So they want to be a good representative of an institution. And because they believe that Stanford is a superior institution, so by association they want to be superior too. And maybe it's similar to the belief that clothes from one store are better than from another store. So if you buy a name brand, that must mean something about you. Now we can also check on how similar groups are by initially conducting statistics on demographic variables from both groups. Because if we have participants in both groups, we don't want the difference to be because of a significant age difference or a race difference or a religious difference. We want it to be due to the main effect or the main problem that we are investigating. So we want to make certain that other variables do not influence the outcome that are unimportant to us. Okay, the difference between experimental and observational study. Here's another way to show some of these same things by looking at the characteristic. The experimenter selects the conditions. We've talked about that. We can have random or non-randomization among conditions, and I'll show you this in just a minute by looking at community studies. And remember, we have clinical and community studies under experimental studies. And we have something that's active. The treatment is under the investigator's control is the main difference. And you can take smokers and assign them to different treatments, for example. Now, experiments are the only design that address causation. They're the only design that addresses causation. And we're going to be talking about causation as a separate topic, but if we're talking about a design that measures causation, you would say it's an experiment. Now, an observational study, on the other hand, shows association. Association can be correlation. We mean that two things happen in close proximity, but they're related in some way, and oftentimes we think that that things are related, even though they may not be. They just don't make sense in terms of being related. The best example of an observational study is Snow. He could have drawn a sample from people who drank water from each water company rather than doing a census sample, but he didn't assign those who were sick versus those who were not sick, right? So he did not manipulate the conditions, he just observed what was happening in nature. So we have non-random allocation. Sample of subjects may be randomly selected. I mean, we could pick some people, as I mentioned, from who drank the contaminated water, because we can't investigate all of them are from that drank from well 1 and people who drank from well 2. But normally on the variable of interest in terms of illness, we don't randomly decide who becomes ill and who doesn't. That would be unethical, and we would be in serious trouble quickly. So what we do is we observe what happens or has happened in nature. And what we do, another example of an observational study is we observe smokers and healthy non-smokers to see what happens to them in regards to their medical conditions. Okay? Now I want to talk about a community trial. A community trial, we know, is an experiment in which a unit of allocation to receive a preventive intervention regimen is an entire community or political subdivision. And I'm going to show you community trials. And probably one of the best examples is the Stanford Three Cities Project. That's a study that I worked on when I was a Stanford student and ultimately graduated from Stanford. And it deals with 3 cities, and the cities are very similar. And we had Gilroy and Watsonville were the intervention cities, and Tracy was the no treatment city, and I'll talk more about that, but I want you to be locked into what I'm saying here. Gilroy was a media-only community, and Watsonville was a media plus intensive face-to-face programs to subgroups at high risk. And the two cities showed general improvement in comparison to the control city. Now, so let's look at this for a minute. I want to show you a drawing. Whoops, I want you to get that down. Hopefully you've seen that in your manual. I was slow to press the button to move the slide, but I hope that doesn't interfere with your concentration. But here's a drawing. Now what we talked about, as you recall, is that Tracy. This is this is a mountain site. This is the I would like to introduce to you an example of a community trial. And the most famous one is the Sanford Three Cities study, and it was the first. The chief investigator was Jack Farquhar from the School of Medicine. He was a community medicine person. This is a study I happened to participate in, and I want to lay it out for you as to conditions and what was randomized and what wasn't randomized and things of that nature, so that you have a pretty good understanding of it. We had three cities, obviously, Gilroy and Watsonville, and they were the intervention cities, and Tracy was the no treatments city, and I'll explain to you why. Now the city that received the super duper enhanced intervention was Watsonville. So they received media plus an intensive face-to-face program for all kinds of risk factors for cardiovascular disease. And Gilroy received a lesser treatment, but they did receive treatment. So we had a media only group, and that was Gilroy, and we had a media plus intensive face-to-face interventions or group programs, and that was Watsonville, and Gilroy served as the control group. Now, excuse me, I said no. Tracy served as a control group. Now, here's our diagram of it, and you can see that we use media. And so why Tracy was a control group is because the television towers that for Gilroy and Watsonville were on top of these mountains and faced in one direction. They were unidirectional. Tracy did not receive the same programming, and we used every known means of programming, of media that we could. We used radio, television, newspapers, flyers, letters. We did radio interviews, we did television interviews, all on cardiovascular topics. We had press releases, so the media came to talk with us, etc. Now, one of the main problems of any community intervention is contamination. And what we didn't want to see happen is that people from Tracy would come to visit relatives in these two cities or vice versa and share information about the intervention they were going to receive, because that would be a bias or an error, and we didn't want that to go on, and that has happened in big studies and is made, and they become null and void, and all the money spent was for naught. So we did tests for contamination effects and found out that it was very minimal, wasn't worth worrying about, and what we thought might occur by people visiting one another wasn't nearly as big a concern as we believed. Now, next, we made certain there was 45,000 people total here. We made certain we did a comparison of the cities on demographic variables, and we also demographic variables and any other factors. We found the cities not to be significant on any of these variables that would give one city an advantage over the other. Now, between Gilroy and Watsonville, we randomly assigned the city or the unit, depending on your phraseology, as to who is going to receive the super duper treatment and who was not going to receive the super duper treatment. Obviously, Tracy didn't receive it because they were not in the viewing area and we didn't want them to be. So randomization by unit, not by individuals within the unit, but by unit or city of focus occurred. Okay? Now, in terms of the face-to-face programs, we could randomize people to two conditions. Okay, and that would be your traditional social science model. Now, these are all the famous community, well, they're not all, these are some of the famous early community trials that went on, and you can see that they went on across the world. Stanford was the first, and you can see the dates, and you can see the amount of money that we got in late 1970s dollars. It was a very expensive study at $5.2 million. Then we did the Stanford 5-city study in the early to mid 80s, and the price tag was $11.1 million, so very expensive. And you can see all the places that they've been done, and you can see that we had 45,000 in the first study, and we had 350,000 in the 5-city study. But you can see that the studies were done internationally. We had the Swiss National Research Program, and we had the Heidelberg study, etc. Now, let me mention that community trials are still alive and well, but predominantly they are not conducted in the United States because of their cost. The main place that a community trial goes on still today is in the United Kingdom. They're still popular, and they're trying to their impact and focus, their public health focus is on changing the norms and behaviors of a community. And so maybe that will help you in your focus in distinguishing between an experiment and an observational study. Okay? Now, what I did is I helped to do a lot of field testing. We did a lot of field testing to see what we thought might work in the way of a particular intervention. We focused on weight reduction. We focused on smoking, exercise, nutrition, and a variety of factors that we are all aware of today to help keep people well and maintain or enhance their immune systems. Now I'd like to talk to you about a clinical trial. A clinical trial is something that you often hear about on the radio if you go into Indianapolis and you're traveling in that area, and they'll come on with a public service announcement or a PSA, and we use PSAs in the three cities studies too. But they will come on and invite you to participate in a study if you meet certain criteria. Okay, and um, so if you meet those criteria, you are invited in for an interview, and they follow up to see whether you meet all the specifications for the trial. Now, a clinical trial is generally known as a randomized controlled double-blind study. And this is a big word that you will hear, and this is the study that people believe is the premier study that an investigator can do, where um, both the investigator and participants are blind to what intervention they're going to receive. Are they going to receive the super duper intervention? Are they going to receive usual care intervention? Or are they going to receive no intervention at all? And what I want to do is I'll start with therapeutic trials, because those are the ones normally that I think you hear about. So if I say clinical trial, and they're to test safety and efficacy or effectiveness of an intervention, you can think of three primary types. There's a prevention trial, there's an intervention trial, there's a therapeutic trial. So if you split that diagram from the very beginning and look under experimental studies, you will see community trials, and we've listed those. And then under clinical trials, you know that there are three different types, and you got to be able to distinguish those. But if you can remember SCIT, you should have no trouble in doing so. All right. Now here's a therapeutic trial, and it's an experiment where the agent or procedure is given to relieve symptoms or improve survivorship, extend life in diseased individuals, cancer patients, for examples. So these are often drug studies. Now don't misunderstand. These kinds of trials are used for, or therapeutic trials may be used for other reasons, but these are the best examples of them. Cardiac rehabilitation is a good example of a therapeutic trial, because a person already has a disease, and you're trying to do the following: reduce or eliminate long-term impairment, disability, suffering, or promote adjustments to your remedial condition, and you want to keep them from deaths. We talked about in investigative process earlier on the slides, that we said that death is not always an outcome, so I refer you back to that. Okay, an intervention trial. This is a study where the researcher intervenes with a disease for people at increased risk. Could be obesity, heart disease, stroke, diabetes, cancer, and the like. And I was involved in one of these too. It was the Mr. Fit, or multiple risk factor intervention trial, and we had contamination effects. So we had, I think, 6 or 7 hospitals. We found that those that were receiving instruction and help in courses in obesity, heart disease, stroke, diabetes, and cancer were sharing information with those um, those hospitals that were not the intervention hospitals. So it washed out our results for the most part. But one group, or in this case, a series of hospitals, received the experimental condition, and the others that were involved received the usual treatment. And as I mentioned, we focused on hypertension, cigarette smoking, lowering cholesterol, and the main focus was on reducing coronary deaths. The study did best in reducing cigarette smoking, and there was a 6-month follow-up to this. But again, the investigators talked amongst themselves, so it primarily washed out the benefits of the treatment in trying to talk about a distinction in terms of did the approach seem to work better on hospitals that were matched on a whole lot of different variables, demographic included, and we could not draw that conclusion. And unfortunately, what we found was a null hypothesis, and you try to avoid finding no difference. And $1 million were spent on this. In comparison, institutions, for the most part, just simply did not want to look bad. So if I ask you what an intervention trial is, you can think of Mr. Fit, and you can think of, let's go back here, it's an intervention trial, so it's secondary prevention. Okay, so we covered a therapeutic trial. We said best example probably was a drug trial. Okay, now I want to go to a prevention trial, and this is a wellness trial. This is, I mean, it could focus on any dimension of wellness. What I'm presenting to you is all physical health issues, but you could focus on spiritual health. You could focus on any number of other areas in the wellness arena and have it be a prevention trial. Okay, this is where the investigator determines the effectiveness of a prevention procedure. So we're focusing on exercise. I mean, these are really people who do not have the disease, right? If you think about SCIT, and you need to be thinking about SCIT and the application to each one of these slides I'm talking about. So we're going to focus on exercise and healthy eating habits to prevent heart disease, focus on healthy weight, not weight loss, and maybe toothpaste or a brush to prevent gingivitis. So we're interested in maintaining good nutritional status, physical fitness, and quality of life. So that's what we're trying to accomplish through a prevention trial. And we want to stop something before it starts, before it gets underway, because we believe that we can have a much greater impact if we do so. Now, I think I've talked about healthy weight before, I'm certain I have, and I want to remind you about healthy weight and not just weight loss for aesthetic reasons. Too many people seem to engage in weight loss just for aesthetics.